person for having conducted so many webinars. And when I consider this as a good opportunity to introduce my fellow periodontists. And one more common factor is that we did a PG from the same institute, my good friend, Dr. Jerry Marman, who is a Kochiite and joining us from the beautiful small country Seychelles, which is on the eastern coast of Africa. So Dr. Jerry is brought up in, not brought up in Cochin, but he was born, yes, in Vaisla. And his parents are still there. He did his Bachelor of Dental Surgery from Christian Dental College in Louisiana from 2003 to 2008 after his schooling from Scottish, and completed his MDS in Periodontology from Government Dental College Kozhikode from 2012 to 2015, followed which he was working in Government Dental College Alleppey, Thrissur, and then went on to join the Ministry of Health in Seychelles. Presently, he is the head and senior dental officer of the District Health Center in Seychelles. And he is a very apt speaker in the sense that he was just mentioning to us that he is a periodontist who is working in the dental practice setting. And therefore, the topic is very apt. And definitely, we know Jerry as a young, enterprising youngster who is here to talk about perio in dental practice. So welcome, Dr. Jerry, and over to you. Thank you.
Thank you. Thank you. Thank you. Thank you. Can I start now?
Yes, yes.
Dr.
Thank you, Dr. Vivek.
Okay.
You can start.
Yeah. Thank you so much, Sir Vivek, sir, for those wonderful words. It's nice to see you here. And thank you, Dr. Brijita and Dr. Matthew, for arranging this webinar and giving me an opportunity to speak to all the IDA members in Kochi. Like Dr. Vivek said, I've been in Seychelles for past 4 years now, and mostly I'm doing general practice. There's only one day where I practice perio. It's a specialist OPD day on which I do just perio. The rest of the days, basically 4 days, I'm practicing full general dentistry, and most of my colleagues here on a regular basis, they talk about certain perio cases which come to them and how to manage it. So based on that angle, I'm going to speak today. Our basic aim today is nothing but to understand the basic concepts because I understand that most of you are doing general dentistry. So just to understand the basic concepts in perio, basic certain changes that are coming into perio in recent years, especially the changes in the classification. So so that you are well aware of what you are speaking about and what you are practicing. I believe I'm a person who believes that first of all, you should have the knowledge before you start practicing it and making it your skill. So with no more delay, let's start. The topic, like I've said, is the basic periodontal management in general practice. Okay, so what we'll have is an interaction more than me just speaking the whole time. So I'll ask some questions in between. I just want to know what is your perspective, what do you think, so that I can give the lecture according to what you need. Okay, so let's start. So this is the first slide that we have. So here what I've put are just two pictures. I've put, let me put this as picture number 1 and picture number 2. Without any other clinical parameters that I give you, can you just look at these pictures and tell me what, or can you just diagnose it? Just a basic diagnosis. Patient has come to you. You've just opened the mouth of the patient and you're seeing picture number 1, a patient in picture number 1 and a picture number 2. So can you just tell me on just based on this view of this picture, what is the diagnosis that you will have in your mind before you go into anything else? You can just put it in the chat so I can see. So from there we can move on. Anybody? Picture number 1. So you can put 1 and an answer for that, 2 and an answer for that, so that we know what you're thinking and why you came up with that answer. We'll then discuss. Okay, somebody has said 1 is generalized gingivitis with localized periodontitis with lower anteriors. Yes, 1 is gingivitis, plaque induced. Okay. Okay, so at least 2 of you have answered this. So just to probably generalized periodontitis. Okay, so we are not showing you all the teeth here. So in the second picture, so let's look at that small area and then say. So it, yeah, very good. Shama Ananda said it is one can be gingivitis and two can be periodontitis lesion. Okay, so yes, by looking at the picture, what we see here is that in picture number one, you can just see all the gingiva is inflamed here. You can see certain plaque accumulation or calculus accumulation along the tooth surface, and you can see inflamed gingiva here. Whereas when you look at picture number two, you can actually visualize the root surface. You can see gingival recession here. You can see small black triangles or areas where there has been bone loss. So from this basic thought in your head, you can come to a basic diagnosis. Okay, this is something that has progressed a lot more as compared to this. So this is something where the lesion is confined within the gingiva. The lesion is confined within the gingiva, whereas in this one, the lesion has progressed more into some other supporting structures of your tooth. Which are those supporting structures? Your periodontal ligament, your cementum, and your alveolar bone. So it has progressed to these structures. So it is more progressive and it has caused more destruction. So based on that, we can say that this is gingivitis because it is an inflammation. Itis means inflammation. So inflammation associated just to gingiva. There is inflammation within the gingiva, whereas this is periodontitis. Periodontitis. So that is inflammation. Again, itis, again meaning inflammation, but it has gone into the supporting structures of your tooth. It has gone into the supporting structures of the tooth. Okay, so that is the basic two lesions that mostly you will come across. Okay, mostly you will come across in your general practice. Okay, this is what you will keep seeing. Okay, now, so that is the basic classification, or what you can say, basically you can divide it into, broadly you can classify into gingivitis and periodontitis. So periodontitis is, or periodontal disease as a whole, is a combination of, you can have either gingival lesions or periodontal lesions as periodontitis. So periodontal disease is an immunoinflammatory disease initiated by microorganisms characterized by the destruction of supporting tissues of the teeth. Okay, so if it is just confined to your gingiva, you can call it as gingivitis. And if it is going into your bone, into your periodontal ligament, into your cementum, and there's loss of structure there, then you can call it as periodontitis. Okay, so now let me ask you, can you tell me what are the different types of periodontitis that you know of? Can I again have in the chat section different type of periodontitis that you are aware of? Different type of periodontitis that we have been using for past so many years. We have been continuously talking about periodontitis. You would have had discussions. Yes. Okay. Deepthi has said that it is, Dr. Deepthi has said it is chronic and aggressive periodontitis. Okay. Very good. Now, why I asked this question is that with the latest classification, this terminologies have been slightly altered, or you can say it has been changed. Okay, so why I want to put this forward is that when you are in a group of your colleagues, or when you are interacting with other periodontists or other people, when you present yourself, you should be well updated with what you are doing or what you are practicing. So now if you come and talk to me and tell me that, sir, I have a case where it is chronic periodontitis or aggressive periodontitis, immediately first thing I'll note is that, okay, you are not updated because you are not read or you are not updated on what the changes have come. So now let's see what are the changes that has come. Okay, we will not go into the details because as a general practitioner, you would not need to classify periodontal disease. As a periodontist, I need to do it. But as a general dentist, no need. Just to give you an idea so that when you refer the patients, you should have an idea what you should say, write and send. Okay. So now, according to the latest classification of periodontal diseases, according to the latest classification, which was put forward in 2017. Okay, so a recent change. So I also understand this periodontics is a branch in dentistry which is evolving every single day. If you don't read for even 1 week, you are behind, because that is how the changes occur in this branch of dentistry. Okay, it's ever evolving. Okay, what I studied in my PG 4 years or 5 years back, it's all gone. It's changed a lot. Okay, so you have to keep updating yourself. Okay, and that's why we have seminars like this. So according to the latest classification, what they have done is that, let's not go into anything else, just to see periodontitis. The periodontitis has been now classified into just three categories. Okay, into three categories. You have necrotizing periodontal diseases. Okay, you have periodontitis and periodontitis as a manifestation of systemic disease. Out of that, what we will see is just periodontitis. We just want to see what the gingival classification or gingivitis is just like before. Gingivitis, that is dental biofilm induced and non-biofilm induced. Okay, gingivitis. And now they have come with something new that is known as periodontal health. They have told what is periodontal health. We'll talk about that when we go into certain clinical pictures, and then we'll speak about what periodontal health is. Okay. So at present, now if you want to refer any case of periodont, where you see there is destruction of bone, there is an active lesion, all you need to write and send is, it is a case of periodontitis. Okay. Now this periodontitis has been, what you can say, it has been staged. Okay. It has been staged and it has been graded also. So you don't need to know that. Just to give you an idea, this is the present way you can say at what or what kind of periodontitis it is. So you can say it is a periodontitis stage 1 grade A. Now what are these things? Stages, it's divided into 4 stages. Stage 1, 2, 3 and 4. So what it means, stage 1 is initial periodontitis, stage 2 is moderate, stage 3 is severe periodontitis with potential for additional tooth loss, and stage 4 is severe periodontitis with potential for loss of dentition. Okay, so that is the staging. And grading, they have graded it also, graded as A, B and C based on the progression, how fast the lesion is progressing, how fast the destruction is occurring. Okay, so it is grade A, which is slow, grade B, which is moderate, and grade C, where there is rapid progression. Okay, so now you can ask, some of you will ask, what happened to aggressive periodontitis? Aggressive periodontitis has been incorporated into this, and if you want to say that your patient is having an aggressive lesion, so you can say it is a periodontitis patient with stage 4 and a rapid rate of progression. That's because that's what you used to see in aggressive periodontitis. So instead of writing and sending it's an aggressive periodontitis patient, now you can say it is a periodontitis patient with stage 4 or grade C. Even if you don't do that, you can just send it as a patient's periodontitis patient with aggressive progression. That's a simple way of putting forward when you refer a case now. Okay, so you are not going to use any more older terminologies. You will come up with the latest terminology, so that even when you refer it, the periodontist who receives this will know, okay, this person is aware of what is happening. Okay, so even why he has referred itself makes sense, because he is aware of what the situation is. I hope this is clear. Till now, it is clear. Okay. Is it okay? Can I carry on?
Yes.
Yeah. Okay. Okay. Good. Okay. So, and along with this, I have put the staging and the grading classification, but I don't think you all need to know that. Just for your knowledge, if you want, you can go on to the site of Journal of Clinical Periodontology site, and these articles are all free. So you can download them and just go through the staging and the grading on what criteria they are using. But as a general dentist, I can tell you, if like when I practice here, I have around 25 patients in the morning, which I see from 8 to 12 procedures. You won't have time to stage and grade these patients. So you will have a better way to sideline the perio patients. Some kind of a screening process you can do. So you don't need to do staging and grading. But why I put this is so that you are aware of there is something like this. There is something like stage 1, stage 2, stage 3, stage 4, based on certain bone loss, tooth loss, and your clinical attachment loss. Okay, based on that, you can stage it, and based on your progression of your bone loss, you can grade it also. Okay, so this is the latest classification that has come out for perio, and in 2017. Okay, so I hope you are now clear about this classification. Okay, now coming into the etiology and pathogenesis. Okay, before even you treat something, you should know why. What are you trying to treat? What are you trying to remove from there? Okay, so again, the etiology and pathogenesis is very simple. The concept is very clear in this. I'll just explain. You have your plaque around the tooth. What this plaque will do is that plaque basically means it has lot of bacteria in it. lot of bacteria in it. Any bacteria or any foreign objects which gains entry into our tissues, your body will start responding to that. Your body will start responding to that. And our immune response will get activated. Our immune response will get activated. Now, in certain cases, what happens due to certain factors like your genetic risk factors and your environmental factors, some patients will be more prone to destruction. Why? Because their immune inflammatory response will be very high as compared to another individual who's not prone to it. Okay, or a person who's diabetic or a person who's a smoker. So these are all the environmental or acquired factors. Certain genetic factors, certain genes in your body will make your response much higher. Now, what happens then is that once your response is very high, the body will start releasing certain agents to kill the bacteria. Okay, the aim of the body is to eliminate the bacteria because something has foreign object has entered into your body. Now, trying to eliminate this bacteria, what it does is that it produces large amounts of cytokines, prostanoids, and your certain enzymes known as matrix metalloproteinases. Okay. Now, what it does is that it will break down your tissue and that your connective tissue, that is your cementum, bone, periodontal ligament, all of them will undergo breakdown, resulting in what we saw in the first and second picture. Initially, it will start with inflammation in the gingiva. As it progresses, as the lesion progresses and the biofilm stays there for a long time, the more and more your host response will come, more and more destruction will occur. Okay, so that is a basic. So what happens here is that the initiation of the disease or initiation is brought about by your microbial challenge, but the rest is taken up by your body. And there are other factors like your genetic risk factors, environmental and acquired risk factors, which will add or aid in the destruction of the tissue. Okay, so now we know that what is the cause. The cause is very simple. It is the presence of bacteria in that site, and certain kind of patients will have a high immune response. You have to identify that. Okay, again, in a general practice, you're not going to do that. So what can you do on a broader basis? What is your treatment plan, or how will you approach to the condition? It's very simple. You eliminate the initiating factor, take out the initiating factor, and hope that your host immune response will settle down and everything will settle in. Okay, that is what you can do. Okay, so eliminate the cause or the initiating factor, that is your microbial challenge, that is your plaque. So that is why we always do scaling, root planing, and all those things, basically to eliminate the biofilm or plaque, which is actually the initiating factor for destruction of your periodontal tissues. Okay, so that is your etiology and pathogenesis in a simple thing. Okay, now coming to the diagnosis. How do you diagnose and how do you plan the treatment for these kind of patients who come with gingivitis, patients who come with periodontitis? There are a lot of markers or clinical guidelines that you have to follow, like your clinical attachment level, probing pocket depth, bleeding on probing, tooth mobility. You can do a radiographic assessment and see if there is bone loss, and you can check for tooth loss due to mobility, due to periodontal lesions, whether that patient had any tooth loss earlier. Okay, so these are different factors that you can use to diagnose the condition. Okay, now again, I feel that in a clinical setup, you are not going to sit and measure the clinical attachment level or probing pocket depth of every single tooth. It is not possible, clinically not possible, because you won't have the time for that. So what is the easy method out of this, or how can you screen these patients that come to you with periodontal problems and say that, okay, this I can treat, this maybe I need to send it to a specialist, or I need to refer it after a stage, it's still not improving, I need to refer it to a specialist. What do you do for that? That is when you can use something known as a basic periodontal examination. You can use something known as a screening process known as basic periodontal examination. It's very simple, it is fast, and here we use this. So you can easily screen the patients and allocate to one side, and you can say, okay, this I can do it, or this my hygienist, we have hygienist here, so this the whole group will be taken up by the hygienist. The rest I can do, and the remaining I'll refer to the periodontist. So what is this basic periodontal examination? So the goal of basic periodontal examination is to screen. Understand this, it is to screen, not to diagnose, not to do anything else, but to screen the periodontal conditions of a new patient that is coming to you and to facilitate the treatment planning for that patient. What can you do for that patient with this kind of score? Okay, so you're giving scores and then you're deciding what to do with this patient. The BP scoring will allow the therapist to identify a patient with reasonably healthy periodontal condition, but may be in need of long-term preventive measures. One. Second, a patient with periodontitis and in need of periodontal therapy. You can identify these patients using your this scoring method, that is your basic periodontal examination. Now, how do you do that? So what you do is that you divide whole of your dentition into 6 sextants. You will divide it into 6 sextants. So this is sextant number, just a minute. Yeah, this is sextant number 1, 2, 3, 4, 5, 6. Okay, so you have all the sextants and then you divide them depending on the tooth. So upper right, you will have 1/7 to 1/4. That is from your premolar to your second molar. Third molars are not included. Again, lower right like that. Upper anteriors, canine to canine. Lower anteriors, canine to canine. Again, upper left and lower left. Okay, so I hope you understood how do you divide it. From premolar to second molar on all sides, canine to canine in the anterior region. So you have 6 sextants now. Now, what is the one instrument that you need in your hand for BP is your WHO probe. You should have the WHO ball-ended probe with the markings on it between your. This is very important because whole of our the grading is dependent on this marking. That is, there will be a black band here in that probe between 3.5 to 5.5 mm. Okay, because whole of our recording is based on these two guidelines. Okay, so you should have a WHO probe with you if you want to go ahead with the basic periodontal examination. Okay, now what are the scores that you can give and what are the criteria that you should look for? Okay, so for a quadrant to be considered that you can give a score to a quadrant, you should have at least 2 teeth in that quadrant. Okay, so if only one teeth is that, you don't include that, you include it into the other one and you count it like that. Okay, so minimum 2 teeth, and then you start giving scores to each this thing. Now, how do you give score? So the scores are basically from 0 to 4. From 0 to 4, you have the scoring system. So it's very easy. After you do it 3-4 times, you'll become very fast. You can do it very fast, and eventually you will start screening patients at a much faster rate. Okay, so what is score number 0? Score number 0 is nothing but when you have pockets less than 3.5 mm. That is the first criteria. Score number 0. You can give a score of 0 if the pocket is less than 3.5. Along with that, the patient should not have any calculus or have any overhang fillings. Okay, one thing I commonly see here is also overhang fillings. Can you tell me where do you see the maximum overhang fillings? Maximum site where I have seen here, I don't know how it is there now, but one restoration that we do, most of the dentists don't finish it properly. Can you tell me which site where do you see maximum overhang filling with marginal gingivitis, which will result in marginal gingivitis? When we do that restoration specifically, nobody finishes it properly. Very good. Yes, class 5 restorations. Class 5 restoration, whether you're doing GIC or composite, what I have seen is that nobody values the sulcus, nobody values the gingival margin, nobody values your all the guidelines are forgotten here. They just pack it and even doesn't finish it. Okay, so that is where you will have severe overhangs resulting in accumulation of plaque and then resulting in gingivitis, and then it can progress. So one thing in score number 0 that you have to be aware is that there should be nothing of this. Pocket should be less than 3.5. And the most important one, there should be no bleeding on probing. Okay, I hope bleeding on probing is a very simple concept. And run along the gingival sulcus. Just run around from the mesial to the distal. Just run along and just take the probe for around 30 seconds, and you can start seeing if the site is bleeding or not. If the site starts bleeding there, then you can say that there is some kind of active inflammation going there. That is some kind of inflammation and some infection is occurring in that site. So BOP should also be negative in score 0. So very simple. If everything is clear in that sextant, you give the score as 0. Okay, then score number 1, again pocket depth less than 3.5. It is less than 3.5. Again, no calculus, no overhangs. But what is there? There is some bleeding on probing. There is some bleeding on probing. Okay, how can this occur? Can anyone tell me? There is no calculus, there is no overhangings, nothing. But how can bleeding on probing can occur in this kind of patients? Do you encounter patients like this, where you come, where you see everything is normal, no calculus, but when you run the probe along the gingival sulcus, it starts bleeding? There is inflammation in the gingiva. Why do these patients present? Or otherwise all healthy and everything is normal, but these patients present with this kind of clinical situation, and it starts bleeding. So that means there is some kind of acute inflammation there. There is some kind of infection. What do you do with these patients? Anybody? No calculus also. What else can cause inflammation to start in the gingiva? Anybody? Not malocclusion. Not malocclusion. Always understand. Yes, very good. Shama Anand, Dr. Shama Anand. See, drugs can cause gingival enlargement, resulting in more plaque accumulation. Okay, from there it can progress, but that's a secondary or a sequential thing that can occur. But what can happen is the presence of plaque. Please understand, there's a difference between plaque and calculus. Calculus is your calcified part. It actually, calculus will not cause any harm to us as such. What calculus does it is that it is the best surface for the plaque to accumulate. That is why we are removing calculus. As such, calculus does not have any bacteria, or it's a calcified mass. It will not cause any problem. But the problem is when the calculus is there, it's easy for the plaque to accumulate on top of it because it has very irregular surfaces. If you see under your scanning electron microscope, the surface is very irregular. And that is the basic concept we tell the patients also. Brush properly. And when we do a scaling and root planing or everything, we polish and send the patient. We polish the whole teeth and send. Why do we polish? To make it white? No. To make all the tooth surface smooth so that it does not favor plaque accumulation. So imagine if the patient was little hesitant over the past 2-3 days in brushing or not brushing properly, what will happen? There will be plaque accumulation. That patient will come with what you say initial stage of gingivitis. That is what you will see as bleeding on probing, because that plaque will have bacteria. That bacteria would have caused irritation within the gingival sulcus, resulting in inflammation, resulting in what you have as score number 1. That is your bleeding on probing. Okay, so that is what you can see. So that is score number 1. Again, pocket less than 3.5, no calculus, no overhangs, but there is bleeding on probing. So let me put it here. BOP, positive. Here everything is clear, all good. Now coming to score number 2. Score number 2, again, pocket depth is less than 3.5. But here, now you will start seeing calculus, supra and subgingival calculus. You can find class 5 overhang or class 2 fillings, which have lot of overhang accumulating plaque there. So then you can give that as score number 2. Okay, score number 2. So till now, pocket depth from 0 to 2, it is less than 3.0. It's within the normal range. You can say within the normal. 1 to 3 is the normal range. So it is within the normal range. So you should not be worried. Now, when you have a pocket depth which is measuring more than 3.5, that means, see, your black band is half of it has immersed into the sulcus. That means you don't need an accurate recording like how we do as a periodontist. 3 mm, 5 mm, 6. No, you look, okay, your probe has gone inside and you cannot see the black band completely. Half of it has gone inside. That means now the pocket depth is somewhere between 3.5 and 5.5. Now comes your grading. So that means immediately it will go into code number 3. You will put it as code number 3. Okay, so black band is partially visible, indicating pocket depth somewhere between 3 to 5 mm, somewhere between 3.5 to 5.5 mm. Okay, and then you have score number 4, where the black band is completely disappeared. That means even the 5.5 end of this, if this is the black band here like this, it has gone into the sulcus completely. You cannot see the black band at all. So now you can easily say, okay, it has crossed 5.5. So it is more than 5.5. So that, in that case, you will give a score of 4. You will give a score of 4. Okay. I hope this is clear. The scoring criteria is clear. Okay. In posteriors, if you can see furcation, you can give an asterisk next to that. So you can say in this quadrant, this is the score and this is the asterisk. Now, how do you do the scoring? Do you do for every single tooth? For example, now you are doing from 1 3 1 2 1 1 2 1 2 2 2 3. Okay, and the first tooth that I am taking 1 3, my score I get is 4. Do I need to measure the rest of the tooth, rest of the sextant? The first tooth itself I got a score of 4. Do I need to measure the rest of the sextant? Or can I write for that sextant, can I give the score of 4? The answer is yes. If you get the highest score, you are immediately you can move to the next sextant. That means in a sextant, the highest score in that all the tooth that you have measured, the highest score should be given to that sextant. For example, 1 3 you got, for another example, you got 2, 1 2 you got 1, 1 1 you got 0, 2 2 you got 3, 2 2 you got 4, and then you will not do 2 3. There's no need, because you got the highest score. You can stop there. Okay, so I hope that is clear. So in every sextant, you will give the highest score to that sextant found in that single any tooth. It's not, you're not adding and then you are not getting the average. No, any tooth with the highest score in that sextant will get that score. I hope this is clear. So what is advantages of this? As I start probing, if 1 3 itself, if I get 4, that's it, I stop in that sextant. I give a score of 4 and move to the next one. So I won't waste my time. Okay, so basically you're not doing a detailed one, but you are getting to know that, okay, already in that patient's mouth, there is one tooth which has a score of 4. So you're predicting that in other sites also, there is a high possibility, or in that sextant, there is a high possibility that scores can be in that range. Check for pocket. No, you don't need to do that. That is why we are doing BP. We have only checking pocket, yes, pocket depth on all surface. Again, that is again what you're doing. Where you get the highest score, that will be your recording. Where you get the highest score, that will be your recording. See, when we do either 4 or 6 surfaces. You don't need to do that. You don't need to do that. At least check for 4 surfaces, and wherever you get the highest score, you can that if at one point your probe is going up to 5.5, you stop there. It's crossing 5.5. Okay, that is that. Then you get a score of 4 there. Okay, I hope that is clear. Is the screening part clear? The scoring codes, is it clear? Any more doubts or anything in this? We can clear it now before we go to the end of the session. Okay, very good. Okay, so I hope the BP is clear. And yeah, now we will see. Now we have got the scores. Imagine we have got the scores. Now what do we do with these scores? See, for example, I've put here 4 3 3 and a has asterisk 4 and asterisk. Asterisk means there is a furcation involved. Now how do you what do you say, interpret it? Now these is the interpretation guidance, or guidance on the interpretation of your BP score. Okay, if you get a score of 0, no need for any periodontal treatment. You can motivate the patient saying that you are good, you have maintained your oral hygiene excellently well, continue to do that. Come for a checkup, for if it is a perio, just a perio case, come for a checkup in another 6 months time or a 1 year's time, because patient has maintained for a good period of time. Okay, so no periodontal treatment needed for a score of 0. Now score of 1, what was score of 1? There is bleeding on probing. Okay, so that means the patient at some point was hesitant in brushing, or maybe was not brushing properly for some period of time. That is why there is bleeding on probing, but there's not enough. It's not been such a long time that the calculus start depositing. So you can be sure of that. So you can say to the patient, you can give oral hygiene instructions, which is very, very important in perio point of view. You have to motivate the patient, say that, okay, see, you maintained it well, but there is plaque accumulation here and there because of your brushing. You're not brushing properly. You can show some of the brushing techniques, tell the patient to brush properly, motivate, and you can send the patient off. Done. Another patient cleared out of your morning this thing. Okay, then you have a score of 2. Now here we know that there are certain plaque retentive factors there, like your calculus or overhangings. You have to correct that. You have to remove all the plaque retentive factors, including all your supra and subgingival calculus. 3, Along with this, you can do certain root surface debridement. Okay, you can start doing some root surface debridement. So again, this is again a non-surgical procedure where it can be done by a general dentist. Okay, before they will think, okay, I'm not used to curettes, I don't know how to do root planing. No need of all those things. Nowadays we have ultrasonic tips which comes for subgingival tips in many shapes, sizes and tips, even length. Okay, you have long length ones, fine ones, excellent ones. You can buy a set of that and keep with you, and you can do this same thing. You can remove all the supra and subgingival calculus properly by using these ultrasonic. Okay, then when you come to score number 4, and if you have furcation involvement, that means that this patient will require a complex treatment. Okay, so what you can do in these patients, you can start the initial treatment phase, and then if required, if you feel that it is not improving, you can refer the patient to a periodontist. Okay, you can start referring the patient to a periodontist. So this is the guidance that you can keep, so that once you get a score, you know what all you can do in that patient, and when you need to refer the patient to a periodontist. So anywhere you get a score of 4 and above, or you get furcation involvement, it is ideal that after you finish I'll teach you the phases. After you finish the phase 1, you send the patient, after a review, you send the patient to a periodontist for an opinion, at least saying that this much I have done, this was the score, this is what I've done, now I am referring you for further management. Okay, so that is how your BP score will help you to give you a basic idea of what the situation is and what you can do for that patient. Okay, now coming to the treatment, what all can you do? Okay, so the perio treatment is basically divided into 4 phases. You have to concentrate on just 3 of them. Okay, you have to concentrate on 3 of them, I would say. That is your phase 1, which is your non-surgical phase. Then your phase 4, which is your maintenance phase. These 2 are the most important for a general dentist point of view. Phase 2 is the surgical phase. Okay, certain surgical procedures maybe you can do, so it might play a role for you. And phase 3 is your restorative phase. Phase 3 is your restorative. That means your overhangs, you can correct that, give permanent restorations, all those things that you can do in there. Okay, now let's see what is non-surgical phase. What do you mean by non-surgical phase? Here it is the phase in which you are not doing any surgical procedures. You're doing basic things, what we just studied in BP. You can give oral hygiene instructions. You can give local antiseptic mouthwashes, antiseptic gels for local applications so that the inflammation reduces. Then you can use local and systemic drugs when indicated. Not in all cases of gingivitis, you go ahead and start giving antibiotics. No, in severe cases of inflammation with a lot of pus discharge, a patient is having fever, malaise, you can feel some lymph node enlargement, you can start with a course of antibiotic, anticipating that when you're doing scaling and root planing, there can be a chance of bacteremia and eventually septicemia. Okay, so to avoid that, you can start prescribing antibiotics, but not for all cases. Simple gingivitis cases, no need. You can do a good oral hygiene instruction, give some local antiseptic mouthwashes, and you can start doing your first thing, that is your scaling and root planing. So what all comes in non-surgical? You give instructions, oral hygiene instructions. Then you can give local rinses. That is best is your chlorhexidine mouthwashes, triclosan mouthwashes you can give. Okay, and some topical gels. After that, you can start doing certain procedures that if there is not severe inflammation, even in the first sitting itself, you can go for your supra and subgingival scaling. Again, for supra and subgingival, I understand that all of you will be busy practitioners, so you will not be using any of your hand instruments. You have ultrasonic tips. Use your ultrasonic tips. Change the tips according to the situation. If it is deep subgingival areas that you have to go, use subgingival tips, and then you can remove all these things. Okay, then like I said, in cases where you are anticipating any kind of bacteremia or septicemia and severe infection, you can prescribe antibiotics. So these are the basic things as a general dentist you can prescribe and you can do in the phase 1. Okay, supra and subgingival scaling, antibiotics, local rinses, and oral hygiene instructions. If you are trained little more, you can start doing little bit of root planing also. root planing also. Okay, so that is what your non-surgical phase is. So imagine a patient comes to you with severe gingival inflammation, severe, all the sites are inflamed, severe bleeding. You can see pus discharge from the certain pocket areas and all those things. What you can do is that you can start on certain local rinses, give oral hygiene instruction, start the patient on antibiotic course. After 1 or 2 days, you can call the patient back and start your supra and sub. Don't try to finish everything in one go, because with so much inflammation, you will have a lot of bleeding. Visibility will be a big problem. So do it step by step. First visit, do a little bit. Second visit, by the second visit, the patient comes, the gingiva would have healed much better. You will start seeing more of subgingival calculus. Start removing that. So in 1 to 2 or 2 to 3 visits, you would have done a good supra subgingival scaling, stabilized everything, and then you put the patient on something known as a maintenance phase. Now you observe the patient. You have given all the oral hygiene instructions. You have told the patient about brushing everything. This is very important. In perio, the most important thing is this. If the patient is not compliant, whatever you do is going to fail. It's not like a filling where you do it, done, dusted. No, you have to follow up with the patient. You have to motivate the patient. Then only you will get a success in that case. Otherwise, the patient will keep coming back with bleeding gums. So the patient will think you are not doing properly. You will be thinking what is happening. The reason is that the patient is not motivated enough to maintain a good oral hygiene. So that is very important. So that is what you do during the maintenance phase. After 3 to 4 weeks, you assess the patient. How is the plaque score in the patient? How is the patient brushing? Do you see any more bleeding sites? Has it decreased, the infection or the gingivitis? Has it decreased? As the pocket depth is being reducing? All these things you can assess during the maintenance phase. Then, if you feel that certain areas there are still big pocket depths, you are not able to manage it, that is when you have to decide to send the patient to a periodontist. Then it is up to him. Based on his criteria, he will go do a detailed analysis, and then he will take up the case if necessary for surgical management. Okay, so as a general dentist, again, your concentration should be on your non-surgical phase and your maintenance phase. These two, if you do properly, I can guarantee you 90% of your cases you can clear out without any recurrence. The recurrence factor, I don't know how it is there. Recurrence factor is very important for us here. You cannot have the same patient in a ministry setup coming again and again, because here treatment is all free. So you cannot keep giving the patient again. Same goes for fillings also. You cannot have a filling coming out every 1 week or 2 weeks. You are in trouble. So you have to make sure that when you treat something, it is done properly and it is done according to the protocol, which will make sure that the results last long. Okay. Okay. So now, so that is your treatment phases which are included in the periodontal. Okay, so I hope I gave you a general idea. Now what we'll do is that we'll see certain clinical scenarios in general practice, what you will see and how do we manage them. Okay, the most commonly, like I said, what we see is your gingivitis and periodontitis. So now in the chat section, can you tell me what is the first thing that you're going to do for a patient with gingivitis or periodontitis? First thing, that patient has come, you have done a BP charting, and now you have diagnosed, let's say you have diagnosed the patient as gingivitis. What is the first thing that you're going to do to these patients? First thing that you'll do for these patients. You immediately start with scaling. That's, yes, patient education. Like I said, again, the most important thing is oral hygiene instruction and patient education. That is the core of everything. You do scaling and root planing and subgingival scaling and send the patient back. Within 1 month, he'll come back if he's not brushing properly. In the first place, why it has occurred is because he's not brushing properly. So you have to, like I said, what is the cause? Biofilm. Cause is biofilm. How can biofilm adhere onto your tooth surface? Because you're not removing it properly. So from there, you have to start. You have to start from there. Make sure that the patient is educated well. Patient is aware of what we are doing and why we are doing. You should be made aware that this has occurred because you're not brushing properly. Your brushing technique is wrong. This is the problem. You have to do like this, then you will have a better oral hygiene. Okay, so the first and foremost thing that we will tell the patient is about oral hygiene instructions. Okay, you motivate the patient, you give the patient oral hygiene instructions, and then you can go for, like everybody said, you can go for a supra and subgingival scaling. Okay, then you can do, like if you are aware of root surface debridement, what you need to do, you can go ahead with root surface debridement. In gingivitis cases, no. Will we do root surface debridement in gingivitis cases? In a healthy gingivitis, in a patient where there is only gingival inflammation, will you? Yes, there is no need of root surface debridement. There's no need of root surface because it's just inflammation of gingiva. There are no pockets. Okay. Since I said no pockets, can gingivitis present with some kind of pockets? Can patients present with some kind of pockets? Gingivitis patients. Yes, they can present with pseudo pockets. Okay, they can present with pseudo pockets. Okay, pseudo pockets is nothing but, let me just draw and show you what I mean by that. Okay, see, this is the normal attachment of your gingiva, and this is how it is. Pseudo pockets is nothing but once there is inflammation within the gingiva, your gingiva tends to enlarge. So it sometimes a patient will come with swollen gums, and when you put a probe, the probe will go inside. But that doesn't mean that there is a true pocket. That doesn't mean that there is a true pocket. Okay, I'm not going into the details of what true pocket and everything is. Nothing. True pocket is nothing but when this epithelial attachment here moves in an apical direction. When you have a pocket, this is a true pocket. This, what I've drawn here, is a true pocket. What you see here with the attachment here is a pseudo pocket. So you can, sometimes you will put a probe and you will see your probe going to 4 or 5 mm. That's nothing because the gingiva has enlarged. And that is why you are feeling that. Okay, so after you finish your scaling and root planing, you ask scaling and subgingival and supragingival scaling, you will feel that everything is fine after that. Okay. Okay. Okay, so supra and subgingival scaling. And then you can go for certain kind of systemic and local drug delivery. Again, systemic only if it is required. You have to assess, follow the criteria properly. Please don't start prescribing antibiotics for every single patient. It makes no sense. Okay, so be very, very prudent in how you select the patient that requires systemic antibiotic therapy. Local drug delivery, you can use mouthwashes and gels. As a specialist, we use certain kind of delivery which goes into the pocket. Again, that is only if you have practiced and you know what is the indication for that, go for that. If not, the local delivery can be simple mouthwashes and gels that you can use. Okay. Now, after all this, if it's a gingivitis patient, within 3 to 4 weeks, you will see a complete, reversal of everything. It's completely reversible. The whole of gingivitis will disappear. The gingiva will become healthy and clean. Okay, it will be fit, or you can say perfectly healthy. That is what gingivitis is. Periodontitis, once what is lost is gone. It's very rarely you will have complete regrowth of structure there. It won't occur. Okay, and some cases, after all this that you do, when you recall the patient back, you will find that there are still deep pockets. You will find that at some points your probe is going way inside and it's bleeding from there. There is pus discharge from there. At that point, now it's again for you to decide that, okay, this is the time to send the patient or refer the patient to a specialist and to make sure that that site is treated for. Okay, so both in gingivitis and periodontitis, the phase 1 can be managed by a general dentist. Okay, you can do that phase and then you can send it to the periodontist. Okay, and you can even follow it up with the periodontist, what they are doing, what was the treatment protocol that was followed, and what is the outcome that they have got after 6 months or after 1 year. Okay, you can keep a track on that patient so that you can come to know what is happening. Okay, now these are certain cases that this is here. I don't keep any records, so these are all from the my PG time. I found out some cases and just showing you simple non-surgical periodontal therapy. What are the changes that you can see? This is just after 1 or 2 sittings of simple scaling and root planing. Imagine the patient coming to you like this. This is what you will get after that simple phase 1 therapy with local application of drugs and everything. Okay, so this is another case. Again, pre-treatment, look at this. This is what you get after this. Okay, sometimes even periodontitis cases, you do phase 1, it will get stable. The lesion will become stable. You will not have any more, the pocket depth will reduce and you will not have any deep pockets. You can maintain the patient like that with you. You can maintain that patient like with you with the consideration that you are following up the patient regularly. Okay, so even non-surgical periodontal therapy can be used for periodontitis cases also, and you will get excellent results. Okay, but what is required for surgical and what requires an attention of a specialist, it should be referred to a specialist. Okay, again, these are all simple cases. You can see the massive changes that you will see in the gingiva after a simple scaling and root planing. Okay, now, another common condition that we see here is drug-induced gingival overgrowth. Here, usage of nifedipine is very, very, very common. So I come across with lot of drug-induced gingival overgrowth on a daily basis. Okay, so what is the, if you come across this, how do you diagnose this, and what is the treatment you can come up with? Okay, so here again, first of all, you should be aware of the patient's medical history. Okay, a patient comes to you with gingival enlargement, and then it will present to you as simple gingivitis case, okay, or a periodontitis, because you will see enlarged gingiva with plaque and calculus in it. Why? Because once the drug-induced gingival overgrowth, it doesn't occur over 1 or 2 weeks. It's a slow process which keeps on accumulating, and during that time, what happens? Your oral hygiene methods will be compromised. That means your brushing techniques will be compromised. Your brushing will be compromised. So eventually, what happens? It's once it starts hurting for the patient because of the increase in the size of gingiva, the brushing will reduce, or he won't do that well. What happens? Plaque will accumulate, calculus will form, more plaque. What will that lead to? That will lead to a secondary gingivitis in a patient already who's having gingival enlargement due to the drug. So it will be a combined lesion by the time it comes to you. Okay, so first and foremost, you should know a proper medical history of the patient. Okay, and then you should know which all are the drugs that will cause gingival enlargement. What are the most commonly used drugs that can cause gingival enlargement? That is your phenytoin, nifedipine, and your cyclosporin. And I'm sure most commonly we'll come across phenytoin and nifedipine. Okay, so once these two are correlated, and along with the clinical features, once it is correlated, you can say, okay, there is presence of gingival enlargement. It can be due to drug induced. Okay, so what are the treatment as a general dentist? What all can you do? Okay, so you take a history. Now you note that the patient is on phenytoin, the patient is on nifedipine, and then you tell the patient, okay, see, this is the situation. This is what we are going to do. Again, start off with our basic plan, oral hygiene instruction. The patient should be told about brushing and maintaining a good oral hygiene. You can give chlorhexidine mouthwashes. You can do a scaling and root planing, and along with that, you should consult with the medical doctor and ask if there is an alternative for phenytoin. Something else can be given. Okay, for nifedipine, can you give something else? Okay, because you want to take that offending agent off, which has already started this gingival enlargement. Okay, now once you do all this, if the possible drug substitution is done, scaling and root planing is done, OHI and chlorhexidine rinses, you can have two outcomes. One, you will see that it is the lesion is regressing. The lesion is regressing, the size is reducing, the inflammation is coming down. What you just need to do, keep the patient in your maintenance phase. Maintain a good oral hygiene and keep the patient in your maintenance phase. Keep a regular check on the patient. Okay. The second thing is that after doing everything, there is still persistent gingival enlargements. Okay, still persistent gingival enlargement. Then you can, even after drug substitution has done, the enlargements are not going. So that means it has become fibrosed. Now it is an option for surgical options. You can think of surgical options whereby you can either, if you are skilled enough to do it, you can go ahead and remove it. If not, this is the time again to refer to a specialist, because now the surgical options are wide. You can either go for a, this is a case with a simple just a non-surgical therapy which was done. This was a patient with nifedipine induced gingival enlargement, and you can see what happened, secondary plaque and accumulation in that patient. And this is just after phase one. Just after phase one, the patient showed massive improvement. The drug was also substituted. But the problem with this patient had, the patient had deep pockets because of the lesion staying there for a long time. So we had to do a surgical intervention to correct that also. Okay, but this, what I'm showing, is just after the first phase. As a general practitioner, what you can do and what results you can achieve. Okay, what results you can achieve. Okay, now some cases, what happens, the lesions will be big enough, you will have to excise it. So you can either opt for gingivectomy, where you can cut off the excessive amount of gingiva. Again, there are a lot of criteria for this. You cannot simply keep chopping the gingiva because you have to assess many factors before you plan this. Okay, there are a lot of criteria that you have to think about before you cut off the gingiva. Okay, because you need to assess the attached gingiva, the amount of vestibular depth, all these factors matter. So at this point, if you are not confident enough about your procedure, then it's the time to refer to a specialist. Okay, and then they will do a gingivectomy procedure, and this is the outcome that you can get after a gingivectomy procedure. Okay, again, so this is where you're just cutting the gingiva. It's purely a gingivectomy procedure, whereas this one, they have raised a flap here. They have removed the excessive gingiva, raised a flap, so that any need for bony operations, any changes that you need to the bone, you can do that. So a flap is raised, whatever is done, curated, bone is reshaped and then sutured back, and this is the outcome you'll get. Okay, so that is the management that you can do for drug-induced gingival overgrowth. Okay. The last one that we are going to see is endoperio lesions. Okay, again, very commonly that we come across is your endoperio lesions. Again, this Simon Glick Frank classification is a very old classification, but why I put this forward is it's very easy to relate with most of you. There is a new classification which has come in 2017. Okay, for endoperio. We'll not go into that. Just based on this, we'll talk. Okay, so you can have 4 or 5 types of endoperio lesions. You can have a primary endo lesion, a primary endo, secondary perio. That means first primary endo means it's just a pulpal problem. Primary endo, secondary perio means something occurred in the pulp, the infection spread into the periapical area. From there, it has reached your periodontal tissues and it is causing destruction. Same in the reverse is your perio. You have a primary perio lesion, purely perio. And sometimes you can have a perio lesion that can reach till the apical end, resulting in a retrograde infection, resulting in pulpal death. And that becomes a secondary endo. Primary perio, secondary endo. And sometimes you can have both lesions occurring concurrently. And that is what you call as a combined lesion. Okay. So here also, what all you need to do is again come to a proper diagnosis. But what it is, whether it is a primary perio or a primary endo. Can anyone tell me how do we come to that conclusion? How do we come to that conclusion? How do we decide whether it is primary perio or primary endo? Very two simple tests that I've put forward here. We can use that. What is the most common test that you can differentiate between an endo lesion and a perio lesion? Most common test that we can do so that we can eliminate, say that, okay, this is purely endo or this has an endodontic involvement for sure. Whereas if you do the other one, you can say, okay, this has no endodontic involvement, but this is a perio involvement. Anybody? Yes, it is your vitality test. It is your pulp vitality test. Okay, pulp vitality test. Okay, so a patient comes to you with an abscess. Patient comes to you with a lateral abscess you are seeing. You want to see whether it is a periodontal abscess or a pulpal kind of periapical abscess. Okay, how do you differentiate? The first thing, you can do palpation, percussion. You can check for mobility. You can check for pockets there. You can do a fistula tracking. But the most important criteria here is your vitality test. If the vitality test that you do, hot test, cold, electric test, if it is not responding to any of this, then you can come to the conclusion that the pulp is non-vital. The pulp is non-vital. Okay, so that means it is primarily an endo lesion. The pulp is already dead and it's an endo lesion. And then if you see, and there are no pockets around the tooth or anything else, just an abscess and a non-vital tooth, it's a very clear-cut case that it's an endo lesion, just an endo lesion. Okay, sometimes you can have a pulp that is non-vital but with a pocket. So now there is a perio component also in it. Then you can use certain other tests like your x-rays. You can use x-rays, and based on x-rays you can come to a basic conclusion whether it was initially perio or initially endo. Okay, how do you do that? Radiographically, how do you, basic concept is very simple. If this is your tooth and in the radiograph, if your lesion is here like this and then it is progressing towards the periodontal part, you will have always a primary endo lesion like this. Okay, primary endo lesion like this. That means the radiolucency will be much wider in the apical area, and it will be tapering towards the coronal area. Okay, whereas if it was a primary perio lesion, if it was primary perio lesion, what you will see is that you will see the bone loss like this. That means wider at the coronal end. So the disease started here and it started progressing down. Here the disease started here and then it is progressing towards the periodontal tissues. Okay, so on based on radiograph, you can make a general assessment. Okay, whether it's primary perio or primary endo. Okay, so you combine all these tests and you can come to a conclusion. Okay. Now again, we'll just go through few cases. This is again a primary perio case with a secondary endodontic lesion. Okay, which was again, it was done during my PG time. See, deep pockets, the tooth was non-vital. So we got the RCT done and then we opened up that site. So there were deep pockets. And this whole site was then, what we did is that whatever defect was there, we tried to fill it with bone graft, use certain membranes to close it up, and then you give the sutures and pack it up. So this is a primary perio lesion with an endodontic involvement. So it was a deep pocket persisting for a long time and the tooth had become non-vital. Okay, so here we did. So in this case also, the important thing, which treatment you do first. Always remember this, always it is your endodontic treatment which you should start first. Even for cases like this, where there is primary perio also, you should finish the endodontic treatment before going ahead and placing any grafts or anything. Okay, the endo should be finished and then only you can start the primary perio procedures. Your phase 1 you can do, but the surgical phase should be done only after finishing your obturation. Okay. Then this is another case. This is from a textbook. Okay, this is from a textbook just to show you the picture what I explained before. Can you see the lesion here? A big lesion here, and then it is tapering towards this thing. Can you tell me what is a lesion? What kind of lesion this is? Primary perio or primary endo? Primary perio or primary endo? Yes, it is a primary endo lesion. Primary endo lesion, which had become non-vital, created a big abscess, and then there was a pocket also. Okay, what is the treatment that you do in this? What is the first treatment that you do in this patients where there is primary endo? Yes, you just do a root canal, and in most of the cases there will be complete recovery of the bone loss that has occurred due to endodontic involvement. Okay, there will be complete recovery. So you do RCT and then you wait and watch, and then you wait and watch. Okay, then if you feel there are still persistent pockets and this thing, then you can plan for a periodontal intervention. Okay, so that is one situation. Another situation that we can have is where it can be purely, can you see this? This is a radiograph, again a textbook picture. This is taken from a textbook. This is a picture that they are showing. See, severe bone loss, almost till the middle apical third there is bone loss. So after phase one, when they took a picture, repeated a radiograph, they saw a big lesion. Now, what is the treatment that you will do for this? How will you proceed from here? How will you proceed from here? So you know that it is a primary perio lesion. Now, what all will you do to treat this? What diagnosis test will you do? And then what will you do? Anybody? This patient is in your clinic. This patient is in your clinic. You took the X-ray. There was severe bone loss. You did a scaling and root planing, repeated the IOP, and then you saw another big lesion associated to the root of the one of the teeth. What is the first things that you're going to do? Yes, very good. First thing that you're going to check is for the vitality of the tooth. No, first thing that you're going to check is the vitality of the tooth. Understand this, until and unless the tooth doesn't become non-vital, there is no point of an RCT. Okay, there is no point of an RCT. Okay, that means the tooth is vital. Then the lesion that has occurred there is purely periodontal. The lesion that has occurred there is purely periodontal. So we try to treat that first. Okay, we try to treat that first. So what again here they have done is the same thing. So once they saw this lesion, they did the vitality test and then they saw that it is vital. So then they planned for a complete curettage or removal of the tissue, granulation tissue, and the lesion from there. So opened up the flap, cleaned it up nicely. No grafting or anything was done because the bone loss was basically a one wall defect. So nothing was done. And this is the recovery that the textbook gives you after 6 months. Can you see the complete resolution or a good resolution of the lesion? Good resolution of the lesion. Okay. So this. Does anybody have any doubts? Am I audible?
Yes.
Okay, fine. So this is very important. Why I put this forward is that most of the time in clinics, we don't use this vitality test to its full potential. Most of us, if I am not aware of this situation, I've seen a periodontitis case, but then immediately I see a periapical lesion. If I don't do a vitality test, you're basically what you're gonna start an RCT on this tooth. Okay, you're gonna start an RCT on a tooth that is vital. See, there is indication for intention RCT if you are planning for a bone graft and everything, because the procedure has a future in it, or you're planning for something that is you're trying to regenerate tissue, so you don't want any complication with any pulpal at a later stage. You can do an intentional RCT. But if you are just a simple practitioner and you do see something like this, don't jump and go and do an RCT. You have to first do, again, the most important thing is the vitality test. And if the tooth is vital, it's responding nicely. If you are electric pulp testing and heat and cold test, if it is responding, that means the tooth is vital. The pulp is vital there. So that means the lesion has occurred due to periodontal reasons. Treat for that. Okay. Again, the intervention has to be done by a specialist. The referral has to go. Okay. So after all this, the most important thing, once you finish all these procedures, like I said, the maintenance phase or the supportive periodontal therapy is the most important thing after all this. If you don't do that, all what you have done will be a big waste. Okay. So supportive periodontal therapy becomes a very essential part of your treatment plan. Okay. Why it is important? Because it will prevent the progression and recurrence of your periodontal disease in patients who have been previously treated for gingivitis and periodontitis. How often do you recall your patient? There is a big criteria for that. Okay, there's a criteria on based on which you can decide whether you want to call the patient, and the criteria is known as Marin's classification. Okay, but the basic thing that you need to do is that once you treat the patient, normally you will follow up the patient for the first 1 year. Okay, if it's a routine therapy and it is uneventful, there was no complications, you did and everything is good, you can recall the patient every 3 months. Okay, for the first treatment, after 3 months, you can recall the patient and see how the patient is. But if it is a patient with a BPA score of 4 and you have, as a general dentist, you have started treatment, then you have finished your phase 1, then you are following up the patient, you need to call the patient on a regular basis. That is what, around 1 to 2 months, you will have to recall the patient and see how the patient is maintaining the oral hygiene and how the sites are. And then based on that, you decide again whether you can continue the patient under your care or whether he or she requires a specialist hand. Okay. So all types of periodontal therapy require continuous follow-up and periodontal maintenance care because of the constant bacterial challenge. The maintenance therapy that has proved effective over time is periodic professional visits. Okay. So simple case of gingivitis, yes, 1 sitting, 2 sittings, you are done. Good oral hygiene instruction, you feel that the patient is doing well and good, that is it. It's done. But as you move into more complicated cases, more cases with periodontitis, you have to have a regular follow-up and a professional treatment plan for that. Okay, that only how you can maintain a good success rate while practicing perio. Otherwise, the problem is you will have lot of recurrence. You will not see it as a big problem like an endo problem where you have a filling, it becomes RCT failure, patient comes back to you with pain. No, but here also the same thing is occurring. The patient is repeatedly coming back to you with gingival inflammation. But if you give that proper guidance, that will not occur and you can stop it at the right time. Okay, I hope that is clear. So with that, I will finish my presentation. Thank you so much to all of you for your patient listening. If you have any questions, I think anything that we need to discuss, we can discuss that now.
Those who have any questions, either you can unmute yourself and ask, or you can actually type in the chat box. Jerry, one question in the chat box. Indications, guidelines for doxycycline prescription for periodontitis patients. Hello, Dr. Jerry. Hello. Can you
Okay.
repeat one
Indication, guidelines for doxycycline prescription for periodontitis. Okay. Again, according to the latest guidelines, yes, I'm coming to antibiotics. According to the latest guidelines, what I think the best thing that you give for periodontitis patients nowadays we prefer is a mox metro combination. It's a combination of mox metro combination is much preferred over doxycycline nowadays because of lot of later studies that I've seen. Your prescription is more, for me it's more, what I have followed is that we stick to more of amoxicillin and metronidazole combination, which gives a much better result as compared to doxycycline. Doxycycline as such, it has specific roles for periodontitis cases, but to be on a broader scale when we are treating, I think sticking to amoxicillin and metro combination is much better for a periodontitis patient. And I think for gingivitis patients, like I said, you very rarely give until unless it's a severe case with severe inflammation where you are anticipating a high chance of bacteremia and future septicemia. That is the only case I think you prescribe for gingivitis patients. Otherwise, there is no need for prescribing antibiotics for gingivitis patients. I hope that is clear. Yes. Okay. Again, now what is the course for Mox Metro combination? Okay. If it is an abscess, the patient has come with an abscess, severe pain, lymph node enlargement, fever and everything, you're planning to give antibiotic course, you start with a 3-day course. Amoxicillin, you start with a 3-day course. You start with a 3-day course and you assess the patient after the 3rd day and you see how the patient is. Then if and only if the lesion is not regressing and it's still bad, that is when you plan for a 7-day course from there. You extend for 4 more days. Otherwise, if the lesion has regressed and you have done enough and the pocket has been, you have cleaned out the area nicely and the lesion has regressed, you can stop at 3 days. That is the guideline which Carranza gives for your periodontal abscesses. So you can stop at 3 days, or what you can say, you can assess at 3 days and from there decide your plan for another 4 days. That is based on your clinical judgment. If you feel that the lesion is not regressing, it's still spreading, then you can continue the course. Fenestration is not marked. Fenestration is not marked during BP. Fenestration is not. We are not going into any detailed periodontal examination. We are not going into any detailed periodontal examination. So there is no need to look for fenestrations. Okay. I hope you know what fenestration is. It's nothing but let me show you clinically how it looks. If this is the tooth and this is your alveolar bone, this is fenestration. Can everyone see that? That is the bone loss that occurs on the labial plate of the tooth. Okay. Now this actually, it will not cause any problem to any patient until unless you are doing a surgical procedure. Otherwise, it will be always hidden. This will come into play only when you're doing flaps or only when you're doing periodontal plastic surgical procedures. That's when you will land up in problems with fenestration. Otherwise, this has no significance as such for our routine practice. You will not even know this. The fenestration, you will not detect this. The other thing that sometimes you can see is like fenestration, you have another defect on the labial plate that is like this. The labial plate like this. The bone loss, This is the bone that I'm drawing. The bone loss will be like this. Can anyone tell me what is this? And then along with this, your gingiva will follow the same pattern of the bone. Gingiva will follow the same pattern of the bone. Yes. So you will have recession in this site. And that is, this thing is known as dehiscence. Dehiscence. Okay. But these are all, it's not in the range. When we do a general practice, we don't have to worry about these things. Again, if there is a recession and it's a progressing recession, you have to plan for a perioplastic surgical procedure, which I feel has to be done by a specialist. You have to refer that patient. You can do the phase 1 and then refer the patient to that this thing. Okay, the specialist. Anything else? Cases without abscess. Again, cases without abscess. Again, you have to do your basic periodontal procedures. You don't need to give antibiotics simply just because it's a periodontitis case. Just because it's a periodontitis case, it doesn't mean that you start giving Mox Metro. No, you follow your same pattern. Oral hygiene instructions, scaling and root planing and everything. And you wait and see. Like you come back to that maintenance phase and you see how your patient is responding. Then you decide whether it needs an antibiotic course or because the lesion is not healing, the pocket is discharging a lot of pus, the patient is in pain. All those factors matters before you decide an antibiotic course. A patient with periodontitis, if he comes to me, I'll simply not prescribe any antibiotic. There's no point because you have not removed the cause. Without removing the cause, if you simply feed the patient with antibiotics, it will regress for some time. Immediate relief the patient will get, but you're not doing any benefit to the patient by just prescribing antibiotics. Anything else? Yes, a regular use of chlorhexidine mouthwash. Again, it is patient to patient. It matters. Some patients here for me have come with gingival, tooth staining. Staining is a very common problem, especially brown color discoloration of tooth can occur if the patient keeps on using on a regular basis for a long period of time. Some, not all. There's some are prone to developing stains. So that you have to again monitor, see how the patient is responding, and then from there you can channel how long you need to give the mouthwash. Guidelines in periodontitis patients. Chlorhexidine, why would you use regularly? You can use it, but not on everyday basis. I use it, but I use it weekly, once or twice after brushing. Once in the night, I dilute it, I rinse it, and I use it. But on a regular basis, if you have problems of staining and some other kind of irritations, then it's better not to use it for a long period of time. Okay. Is gum massages like Metrogel, DG gel, or tiny? Yes, they are very useful. They are useful in that initial phase. Why it is useful is that they will allow the gingiva to recede, or not recede, I say, to recover from that severe inflammatory state. From that severe inflammatory state, it will help to recover from that with your chlorhexidine mouthwash and topical gels or your tannic acid thing. They are all astringents. They act as astringents. What they will do is that while you're doing scaling and root planing, what will happen is that the bleeding will be reduced. Your visibility will improve. You will be able to provide a better treatment as a patient with severe bleeding. Imagine a patient who has severe gingivitis, and if you do scaling on the first day, you won't be able to see what you're doing. It's just doing for the sake of doing it. You are not planning on what you're doing. You're not thinking that I have to remove all the calculus from the sites. No. You're not thinking that. Your aim is just do scaling and send the patient off. No. When you do it, you should be able to make sure that you have cleared out everything. Again, the costs, the biofilm, the plaque, the calculus has to be eliminated. That is a role. So the role for this is to reduce the inflammation in that site. How it will help you? It will help you in the next visit when the patient comes to you. The bleeding will be much lesser. So your procedure, the efficiency and the efficacy of your procedure will be much better as compared to you do it on your first visit. Indications for astringent use, it's for till your first visit. Once your scaling and root planing and your site is cleared off, then there's no point of giving this. You have removed the cause. Then you should be confident enough that it will not cause any more inflammation. Good enough. You can leave it. You can stop it. It's just for that initial phase till you go call the patient for the first visit of scaling and root planing. Anything else, or we are done?
I think no more questions. Almost done. Now I invite our member, Dr. Deepthi PR, for the vote of thanks. Dr. Deepthi.
Thank you, madam. Good evening, all. I am honored to have this opportunity to render the vote of thanks this evening. On behalf of all the members and office bearers of IDA Kochi branch, I thank our honorable speaker, Dr. Jerry Mammon, for the wonderful and highly knowledgeable session on the basics of periodontics in general dentistry practice. Also, we would like to extend our gratitude to Dr. George Jacob and Dr. Pravish for introducing the speaker to us. We thank each and everyone who took their valuable time to attend this session. We would also like to acknowledge the presence of our fraternity members from other IDA branches who are present here now. We would like to thank our President, Dr. Matthew Varghese, Honorary Secretary, Dr. Nevin Thomas, and our Treasurer, Dr. Nidhi Ravindran, for all their support and encouragement. And a special thanks to all the seniors in IDA for their constant encouragement. Last but not the least, we sincerely thank our CDA chairperson, Dr. Brijita Manoj, for her efforts to organize such useful webinars. Once again, thanking all the participants. Thank you.
Thank you, Dr. Deepthi. And thank you, Dr. Jerry. Thank you, Dr. Jerry, for the wonderful session. It was very informative.
Thank you.
Really nice. And thanks to Dr. Pravish and Dr. George. They actually introduced you to me. And it was very nice to have you. And thank you for your valuable time for being with us. Thank you, Dr.
Thank you so much. Thank you so much.
Okay, I'll send you the invitation, the certificate through mail. So please do share your mail.
Thank you.
I'll share.
Yeah, sure. Thank you so much. Bye-bye.
Thank you, Deepthi. Okay, bye. Good night.